Now, our next speaker is a pioneering pediatric orthopedic surgeon with over 20 years of experience. She will discuss with us today the first 1,000 days in cerebral palsy management. Please join me in welcoming Dr. Simone Batuli, specialist orthopedic pediatric surgeon in Reem Hospital.
Thank you for having me. It's a pleasure to be here. It's nice to see a full house and very nice lectures that precede me. In this presentation, we will continue with early diagnosis, early management, and we will also see the importance of proactive management of cerebral palsy. So, as we all know, CP is a very broad term. It's not a etiologic diagnosis. It's an umbrella term that encompasses many different types of pathology. And it's important to mention that the diagnosis of cerebral palsy will not exclude more specific diagnosis. So sometimes the parents tell us, no, my child has is not a CP patient. My child has this and this diagnosis. And CP, it's an important term. Nobody likes it. It's a very old term, but puts the child into the track of treatment. So that's why all the neurologic societies try to keep the term. When I was doing my fellowship in the US, the chief of my department was trying to make us to call it the first neuron syndrome. And nobody knows what is it. Even when we are discussing the cases with other people, when we say the patient has a cerebral palsy, it's a broad spectrum, but everybody knows how to treat the patients. The neurologist, the other specialties will be able to handle the patients and what those patients need. And I'm here talking about this first 1,000 days, not because I want to show how great I am as a surgeon, but to show that it's important to avoid too many of the need for surgery in the later life if we start the management early. So the child will have a better prognosis and we will be happy to operate less on those children. Saying that, it's also important to mention that these are the kids that have good function. Those are the kids that have less good function. So this is the GMFCS classification system, and they divide the patients of CP in 5 levels. So the first 2 levels will have good function. The 3rd level will need assistive aids for walking, and the 4th and 5th level will be more dependent and they will have less functional outcomes. And I'm saying that here because when we see a small child with CP and I have to take them to OT, those are very specific cases because we try to avoid surgery for them as much as we can. So one of the cases that we have to do surgery for those patients is when the hips are lateralizing, when the hips are at risk for dislocation. And this is important to do at this age. It doesn't matter what the age is, because the salvage procedures are very poor in terms of diagnosis later on. So you know, it's very common for me to take this 3-4-year-old child to OT, and the anesthetists tell me, oh, Haran, why are you doing this? This child will never walk. Why this big surgery? Because for them, it's much more work. However, This is why. Because the natural history for the GMF CS4 and 5 are very poor if we are not proactive. So those kids will have hip dislocation, they will have pelvic obliquity, they will have scoliosis, they will be uncomfortable to lie down, they will be uncomfortable even to breathe. So that's why to the patients that have more poor function, we have to maintain more proactive management, including surgery. So this is again another patient with GMF CS5. We see a therapist behind him. And this is the result of GMF CS5 with good proactive management. So this child will never walk, as the anesthetist says, but this child is breathing, is smiling, is having social interactions. So starting the management early, it's important, and this is very intuitive because we will see that this is the brain that will have more, that will be more prone to neuroplasticity. We know that neuroplasticity is a lifelong process, however, the young brain will be able to recover better. So God forbid, if we have a stroke today, we don't want to wait until we are, you know, more mature to start our rehabilitation. So we should never do the same to a CP child or a child that we think is at risk for a developmental disorder. So we improve the outcomes of a CP patient, not only motor outcomes, but the cognitive outcomes and the social outcomes also, and also the burden for the families. So historically, is this that we want to avoid, is doing the diagnosis when the child is not walking, not moving well, and having stereotype movements that will be much more difficult to improve after they are well established. So the early management depends on early diagnosis, and here I will just mention two types of tools that we have. Always structural and systematic approach for early diagnosis are valid. I'm here just mentioning how I learned it. The general movement assessment, as most of you might know, is the analysis of the spontaneous movement of the babies. This is thought to be much more efficient to see the integrity of the central nervous system and the motor function of the child than the responsive type of neurological assessment. Also, Hammersmith is one of the structured clinical examination to diagnose early signs of neurologic dysfunction. This is the GMF-CS level. On your left, we see that is much more we have much more fluent movement. We can see that the baby is able to keep the three members up to the, into the air. They are strong enough to have different patterns of movements. The movements are smooth and elegant. On the other hand, on the other side, we can see the general movements of a child that will be later on known to have CP. We see that the movement pattern is almost a frozen image and a repetition of the previous type of movement. So the child tries to move, but they keep always three of the members in contact with the surface, and they are not strong enough, and they don't have enough variability of the movement to be fluid and complex as the normal child. So the general movement assessment has good sensitivity, has good inter-examiner reliability, and it's very sensitive and with good specificity. The other one is the Hammersmith. It's nice because it can be used for preterms and also assess the spontaneous movement activities of the baby. So the early diagnosis challenges for us is the lack of training, is delay of referrals to the specialist, and is low awareness among the primary care providers. And a good tool if you don't want to give bad news to the parents, or if you are afraid to have a negative findings afterwards, the child is completely normal and you are suspicious, which is not very common, you can just label the child as a high risk for CP or for other neurodevelopmental disorders, and put the child in the right track for early management. This, I think, it's a good type of way to proceed. So another important message is that the wait-and-see approach is not valid for the new research, and also is detrimental for the prognosis of this child. Not just for the motor function, but also for the cognitive and social interactions that those children will be able to have. So the early intervention doesn't mean only do any type of physiotherapy. We have different types of interventions that are proven to have best outcomes. So what the literature shows is the task-specific motor training involving the child to, involving the families to create opportunities for these children to be more active and more engaging and more with more environmental enrichment is important for the outcomes. The multidisciplinary type of approach is important, and the use of assistive technology. Being an orthopedic surgeon, most of the parents are concerned, will my child walk? But the most important and the first priority for all of us should be the communication. So the child should be able to communicate efficiently, otherwise they will not be involved in the environment and they will not develop as they could. So we have many meta-analyses, big studies supporting that the intervention should be early and should be also specific to promote better outcomes. So we have meta-analysis, we have systematic reviews to help with this type of rationale. And I also want to talk about this book that is very, very important. Roberta Shepard's put together very nice chapters about early intervention in babies with cerebral palsy. Well, in conclusion, it's important to make the diagnosis early, to put the child in the right track of intervention, and it's important for us as clinicians to know what the physiotherapist is doing. Physiotherapy rehabilitation is the first line of treatment of cerebral palsy. I'm there only to fix problems. you know, contractures, the joints that might be out. But the first line of treatment is physiotherapy, and we need to know what type of physiotherapy has been doing for these children. It's important to avoid maladaptive movement patterns. It's much easier to teach the child to move and to walk and to function for the first time in the right way than to undo maladaptive patterns later on. It's important to have policies. It's important to improve our multidisciplinary team approach, and we need to be always hopeful, because the future of children with cerebral palsy can be bright, and we will see good improvement with diagnosis, with more specific and early markers, biomarkers for CP. We can use also tools to improve the function and to help those children to communicate better. Thank you very much.